Good evening, everybody, and welcome to an evening of continuing professional development. It really is wonderful to see all of you here today. I know you've had a long day at work, but I hope that we're going to make this worthwhile for you. It's not terribly long, but this is a training evening, and it is titled Helping Patients Beat the Impact of Diabetes. It is brought to us by BD, and our speaker tonight is Claire Winterton. And this is the start of our preparations for the ICPA Diabetes campaign, which culminates on the 14th of November when we celebrate World Diabetes Day. And obviously pharmacists are intricately involved with our diabetic patients. They are regulars with many comorbidities and require a lot of assistance. And of course, there are also millions of people out there who don't even realize that they are diabetic, and with all the implications of uncontrolled high blood sugar. So at this point, I'm going to stop sharing my screen. As I've already indicated, we are going to be recording this evening, so you will be able to request a copy. It will also be on our website. And Claire, I'm just going to make it so that you can also share the screen. And at this stage, I'm going to hand over to you, Claire. Thanks very much.
Perfect. Thank you very much, Jackie. Hi, good evening, everyone. As Jackie mentioned, my name is Claire Winterton. I'm with the BD Diabetes Care. We're now formerly BD, actually Embecta, going forward. I've been with the Diabetes Care unit for the last 6 years or so. And before that, I was still with BD for 5 years in a different division. So as Jackie mentioned, this evening is largely focused around helping that diabetic patient manage diabetes, because I don't think everybody realizes the impact that diabetes has on everyone's life. And this is around sort of touching those points, how to best manage it. And then also from a commercial aspect, to be able to give a little bit of insight into the commercial aspect from a pharmacy perspective, as well as then how this, how you can actually help your patient and gain a commercial benefit from that too. So please feel free to ask questions if there are. I can't see the chat, so if there is anything in there, if somebody would just alert me to that, Jackie. Other than that, feel free to ask questions. So I'm going to dive in with the start of the training. And essentially, as we said, diabetes is a massive challenge. If you look at some of the statistics that they throw around, you can see numbers like diabetes growing at 155%. In Africa, pretty much 69% of diabetics are completely undiagnosed. They don't even know they have the disease. 11% of diabetics in Africa actually receive treatment. So that is a minuscule amount of patients. And as I say, so there's a couple of other stats there, but what this is all about, if you can actually manage diabetes, in the end, you manage the healthcare costs. And what we are looking at is to say, well, if you can manage those injections and that injection technique, which leads to better control, you can actually manage diabetes. So what are some of the cost drivers? Because everybody looks at it and, when people stand in front of you, they might look at a direct cost of a medication or a needle, those sort of things. But there's been a couple of studies in that done. And what you find is that the largest direct cost of diabetes is actually hospitalization, which accounts for about 43% of that cost. Now, if you think about it, that means if you're ending up in hospital when you have diabetes, it actually means that you are uncontrolled. Because if you were well controlled and you didn't have comorbidities and things, you wouldn't end up in hospital. So what this is actually telling us is that most patients are largely uncontrolled, leading to this hospitalization, and that is where the cost sits. There's obviously the other costs that move down the line, as you can see, sort of prescription medications, physician visits, nursing facilities, they make up a smaller chunk, but the bulk of it is when a patient ends up in hospital with those comorbidities. Now, to control a diabetic patient, you actually need a multidisciplinary team. So you need the patient at the center. We need our physicians and endos. We need our funders, so medical aides on board, our DNEs that maybe do some education. But critical in this role is the pharmacy and the pharmacists. Because if you think about your touch points with a patient, how often does a patient see a physician? Twice a year, if they're lucky, maybe once a year. A DNE visit, they might be allowed one visit in their time that they've got maybe once a year to see a DNE for education. And if you think every single month that patient comes into a pharmacy or subscribes to sort of a delivery service, but they are touched by a pharmacy and a pharmacist every single month, most diabetic patients. So you can already see that you have a critical role in this process where you really can have an impact on a diabetic patient's life and to help better their treatment and their overall control. So that's where this fits in.
Yeah.
Right. So moving on. So what are the challenges with diabetes? Basically, the comorbidities. What you find is that patients still today are struggling with things like stroke and heart attacks. You're having the retinopathy, damage to the eyes, kidney failure. It's still proven that the leading cause of dialysis and patients receiving dialysis is because of diabetes. The general sort of heart disease, and then of course amputations. It's a scary thought to think that today, with all of our fancy insulins and education and diets and everything you can think of, patients are still having amputations done because they are not controlled. So the key here is if we can prevent complications, that is critical to preventing those escalating costs. So what it actually costs to manage a diabetic patient. Right, now, when it comes to your pillars for managing diabetes, I think everyone is fairly familiar with the first three. So we need to check our glucose levels, we need to eat healthy and our dietary requirements. They encourage us to be fit and do some exercise, but very seldom do people focus on the injection itself. Now, what people, doctors, diabetics themselves, what nobody realizes or thinks about is that the way you inject your insulin is actually critical to how well the body absorbs it, and then ultimately to how well it can control your blood sugar. So you might be doing all of these first three things in that, but down the line, if you're not injecting like you should, you could actually negatively impact that control and not be controlled in the end. So that is why we focus so much on this, because if you don't actually inject your insulin correctly, you largely remain uncontrolled. So what are the things that affect this injection? Now, what they've discovered, well, let's put it this way, they've done a lot of clinical studies and trials around diabetic patients, and they looked at the skin structure. And what you find, so this little representation here of the different areas of the body shows you muscle, your fatty tissue, and at the top, your skin. And what they discovered is that the top two layers of that, so that your dermis, your epidermis, the skin itself, was found to be between 0.9 and 2.4 millimeters thick. That's it, 2.4 maximum, regardless of gender, regardless of race, and very importantly, regardless of BMI. So all of us, doesn't matter who we are, our skin is the skin. What differs between patients, between all of us and around your own body, it's your subcutaneous layer or the fatty tissue, and then the muscle. So that's what's different between us, not our skin. So what this is trying to highlight is that when patients are on longer needles, for instance, 8mm needles, and a patient injects in an area like buttocks where there's a lot more fatty tissue, most of your needles, including an 8, would most likely be subcutaneous. And with our insulin, as you would know, we want it to be subcutaneous because that subcutaneous tissue absorbs your insulin at just the right rate to control blood sugar. So that's where we want our insulin. Now, with a diabetic patient, it's critical that they rotate their injection sites. So I've got another slide on that. But also you find that not only do they rotate in an area, they very often change the site. So they may inject in the abdomen, the buttocks, they may move to the thigh. And it's also been proven that I think it's in excess of 50 or 60% of patients at some point will inject on their thigh. Now, what happens is when they're on longer needles and they move around the body, then you find that they are at great risk of going right through the subcutaneous layers, so through your fatty tissue, into the muscle. Now, the challenge with muscle, as you can see, it's red, it's active, it's got a lot of blood flow. So what happens is it absorbs your insulin too quickly, so very quickly, and they end up with unexplained hypos. So that's what our little blue block on the side there is explaining to us. So it's unintentional intramuscular injections. So the patient injected yesterday and they were fine. Today they injected and they don't know what happened. They just crashed, the blood sugar dropped, and they don't even realize that it was into muscle. So I
Claire, we seem to have lost you. Can you hear me? Apologies, everybody. I think we seem to have lost Claire. Let's see if we can get her back. Give me a minute.
Sorry, let me share my screen again. Okay, I think I should be back. The challenge with the diabetic patient is that they struggle to trust if they don't feel the injection, if they can't see it going in, they are hesitant when they actually can't feel that and they don't trust they're getting their insulin. But seeing the needle going in and feeling it is not an indication of actually receiving your insulin. It's whether you are controlled or not. Sorry, my screen does not want to change for some reason.
Claire, maybe try stop sharing your screen and then share it again, go into presentation mode, and it should work.
Let me try that. Apologies for that. Okay, let's see. Apologies for that. It's freezing for some reason. Let me just open my thing again. Ah, excellent. Apologies for that. Right. So next topic, we've gone into needle length. So we've touched on that. Shorter is best. The next topic that we touch on is reuse. Now, I know that a lot of your patients stand in front of you and they say that, I've got enough needles, I don't need more needles, I can reuse them, don't worry about it. But what you find is that they don't realize the damage and the risk they're actually causing through needle reuse. So what happens is when a needle is new, you can see from the little picture, it is sharp. It's got a lubricant on it. So our needles actually have lubricant on. They are as sharp as possible, and they are designed to glide through the skin. So hence the title, ease of insertion. So ideally, it should glide through. But what happens is the next time they reuse that needle, instead of gliding through, it sort of moves through in sort of a jagged type action, and it causes damage at that injection site. So the next time, again, and even more so, with our diabetic patients with this extensive reuse, the number of injections they need to do on a daily basis and not rotating, it's actually causing this damage to accumulate. Besides being painful, infections, needles can be blocked, crystallized, all of those aspects. What actually happens is, if we go to the next slide, it builds up into scar tissue. So that scar tissue is what we call a lipohypertrophy or lipos. And that is a lump under the skin. And generally, it starts off small and it gets bigger and bigger. It can be the size of an orange. The sad reality is many diabetic patients think that they have these lipos, or they get them because they use insulin. They don't get it because they use insulin. They get it because of that repetitive injection with a blunt needle causing damage, and then not rotating the injection sites properly. Now, you might sit there and say, well, so what if they got a lump, on the tummy or wherever they inject? Well, what does it matter if you've got a lump? Nobody's going to see it. It probably doesn't even have an impact. But if you think about what I've just said, that it's scar tissue, I'm sure as pharmacists and medical people out there, you would know and have been taught you never inject anything into scar tissue, let alone your insulin. So what happens is the scar tissue is unhealthy. When you inject your insulin into it, it sits in between the scar tissue. It can't be effectively absorbed. So these patients with a lot of lipos, and they've proven like in excess of 64% of patients have lipos, they end up on higher and higher doses of insulin because it just can't be absorbed into the body to control the blood sugar. But while the patient stands in front of you and says, no, I don't need to change that needle, don't give me more, I'm just too lazy to change it, they're actually causing higher insulin use, lower control because they're uncontrolled, and that cost in front of them of a needle, they are not seeing the bigger picture of much higher insulin usage and cost there. But the worst part about it is diabetes complications only develop at sort of a slower progression most of the time. And it only develops, 5 to 10 years down the line when you're getting that neuropathy and retinopathy and kidney failure. You can't reverse it then. And you don't realize the impact of a simple thing like an injection, how it can lead to preventing those complications from developing. So that is the sort of message we're trying to get over to our patients is don't look at what you're doing, like right now, that needle that you need to change and it's a schlep and it's a cost. Look at how well it can assist you to be controlled down the line. And that is the message out there that you need to try to get over to the patients, get them to change that needle. So we've touched on shorter needles, best for avoiding that intramuscular. We've gone on to the needle reuse and then avoiding lipos. Now, with the sharp and short needles goes hand in hand rotation. Not everybody's familiar with how to rotate your injection sites correctly. very often what you'll see in many, many pictures of diabetic patients where they inject, you often see two lipos next to each other, so two lumps. Because what is sort of human nature, when you're injecting 3-4 times a day, you tend to go one to the left, one to the right, one to the left, one to the right, and you end up with two lumps. And that is a classic mistake when it comes to rotation. You don't realize that in each day, it's probably 2 injections at each of those sites every day. That's where the 2 lumps comes in. So correct rotation, this card, it looks complicated and things, but it's really just trying to show you, you divide your area in 4, whichever area you're going to use. You then, so you have quarters, you then move 1 finger space as you inject. If you forget, move to a different quarter. And the idea is that you try to rotate those sites, that you only come back to a new site in sort of a week's time to allow that tissue to be nice and healthy. And that then improves your control massively. So injecting it in the right place and then avoiding this scar tissue formation. So that's what the rotation is all about. And we actually have some of these charts available. You know, if people want to see them or need them, we can actually distribute them. Right, so another topic is just on safe needle disposal, because I think, you know, when we then speak about more needles and changing them, in many people bring up the topic of, well, what about that safe disposal? You know, we don't want to sit with packets of needles and get needle pricks and that. So there is something available that we have, and I think we shared some samples with Jackie and them. It's just a safe clip. So there is devices to help assist with that, you know, additional needles. This little device allows you to clip the needle off, and that way it stays inside the device, which has got a little metal chamber, so you can't open it. It holds 1,500 needles. It's this literally a little bit bigger than a nail clipper. And it's really a great device, because once it's full, lasts a patient anything from 1 year to 2 years. You drop that whole little device in your bin and it's gone. No sharp needles, nothing left behind. So that's sort of a best practice. And we always encourage patients, please never throw your needles into things like loose garbage, any recycle bins. Don't put them down the toilets. And of course, don't just throw them away carelessly wherever you are. So that is best practice around your disposal of needles. Onto the use of your insulin pens, and we've got a slide like this for syringes too. Very often your patients and even yourselves just need a refresher on what is the correct way to use your pen, how to attach needles, those sort of things. So we've got little charts like this which give you like a snapshot of how to use your pen. But if you look to the bottom right corner, it's my bottom right, there's a little QR code, which is you can scan it. And if you can't scan that, you can literally type into Google the URL at the bottom. And those are short videos that we have on YouTube. It's public. Anyone can access it. If you can Google and you can get to YouTube, it's just little generic videos of a patient talking about how to inject with my insulin pen or syringe. It's really nice. It's short. It just speaks about like the obvious topics. And what I love about it, it always mentions, if you're uncomfortable, if you're unsure, talk to your doctor, that sort of thing around it. It just helps that patient feel more comfortable with injecting. Because very often when a patient stands in front of you, they might not want to discuss everything. So ideally, we want to send them home with some of this information, and they can actually watch the video in their own time if they are not comfortable with discussing, their condition in front of you, and with that help and assistance. So that's the same thing based on syringes. But I think in our market, most people are probably on the pens. This slide that's included in the presentation that we send through is just kind of reminders of things that you can use for your patient and things to remember, yourself. So pen needles, they're single use. You're not supposed to be using them more. The little 2 with the line through it on each and every needle tab. that actually indicates don't use it for a second time. You know, basically patients are overwhelmed when they're living with diabetes. So you can use the knowledge and information that you have to assist them to manage their condition. And, you know, these are, as I say, highlights around that. Do we have any questions at all? Jackie, anything at all? Any comments on the clinical aspect?
Hi, Claire. No, I haven't seen anything in the chat group. But if anybody has a question, please either raise your hand or just unmute yourself, and you're welcome to ask Claire at this stage.
Okay.
Yeah,
Perfect.
I don't see
Then
any hands, Claire.
On.
Yeah, I think what you've
100%.
given us so far is very clear.
Perfect. So there we've touched on the clinical aspects of, you know, managing the disease and helping our patients. But as I mentioned right at the beginning, there is also a commercial impact when it comes to the pharmacy. So as much as we are helping patients in that, I mean, it is realistic. You know, you own pharmacies and you work in pharmacies, so it is a business on the other side of things, and it's in the business of helping patients. Now, what people don't realize is that when you have a diabetic patient coming into your pharmacy, a diabetic patient has been proven to be 2 to 3 or to spend 2 to 3 times more than the average patient. So what you find is that a diabetic patient, if you can retain them within your pharmacies, it is a huge plus point. So if you can help patients and bring that value to them around changing needles, about managing their condition, possibly reducing their insulin use, you find that you give them a reason to come to your pharmacy versus any other pharmacy. Because, I mean, if you don't keep them, what stops them just going somewhere else? If you're just giving them a few needles and just doing what they ask, then, you know, what stops them going somewhere else? But besides that, there is also the aspect around the pen needles themselves. So we subscribe to the IMS data that we receive. And this is just some numbers to put out there that you know, come from this last year's data up to July. What you find, this, I've taken a snapshot from just the independent pharmacies. So I've taken out all the others, grouped the independents together. It's around about 75 to 80% accurate. So, I mean, there is some pharmacies and that don't subscribe to it, but those that do are in this group. And in the independent market, what you find from a pen needle perspective, there's around about 276,000 needles dispensed on a monthly basis. Of that, about 141,000 is BD. And when you look at the insulin data within these same pharmacies on a monthly basis, there's around 174,000 insulin pens dispensed. With our patients that are on insulin in South Africa in the private market, it's estimated that there's around about 160,000 patients on insulin. And of that, about 43,000 is serviced through independent pharmacies. So this just comes from that data that's broken down. So around about 43,000 patients are serviced by independent pharmacies. But if you do the maths and you say, right, we're dispensing 276,000 needles to 43,000 patients on a monthly basis, what that tells us is that on average, a patient's getting about 6 needles a month. So yes, you might get some that take 50 and some that take 5, some come 1 month, some don't come for 3 months. But when you kind of just level it out, it actually equates to 6 needles per patient. Now, if I had to say to you, standing in front of me, right, here's 6 needles. I need you to do 120 injections per month. That's 4 days. I need you to do 120. Here's 6 needles. What I'm actually telling you is that I expect you to use each needle 19 times. Think about it. Would any of you reuse a needle? I mean, you shouldn't reuse it at all, but would you use it 19 times? this is what this data is actually showing us. So it's a scary thought as a patient out there. You don't realize what a big challenge it is. And as we've gone through the clinical aspect, the damage that they are doing, it's astronomical. So that is, around the needle itself. So what we do is, with the funders, with patients, realistically getting a patient from 5 needles onto single use can be quite a challenge. We're not Europe at this point in time. So what we've then said is, well, the bare minimum for, at least getting good control is try to move your patients onto a clean needle a day. Those that are using more, fine, that is great. They're changing their best practice. That's exactly what we're looking for. But those that can't, try to move them onto 1 clean needle a day, which is at least 30 per month. So minimum your 30 needles. Most funders are paying for your 30s. So what this then tells us is, if I was to then dispense 30 needles per those patients, the independent pharmacy market should be dispensing 1.3 million needles a month. You're actually doing 276,000. So that gap is 1.1 million that is just not there. And if you equate that to just rands and cents, I'm just using a number, I'm just using a 20 cents, a 40 cents. It actually equates to a lot of revenue that is sitting there that is not even tapped into. You could potentially help a patient manage diabetes with best practice and get a revenue value for that. So sometimes people say, oh, but please, this is a huge number. What does it even mean for my pharmacy? I only have 200 patients. What is it going to matter? Well, it might not look like a huge amount, but per annum, at your 20 cents or 40 cents, you're looking at an additional, call it 28,000 Rand an annum, just for helping that patient to change their needles. But remember, this is not just about that needle and that value you see in front there. It's about retaining your diabetic patient and getting their full basket. So that is what people, again, miss. They just look at, oh, please, just that amount for, an extra needle. But it's about that full basket, helping the patient, getting them under control and retaining them with that full basket. That is where the monetary value sits. But this is just to highlight that even if you looked at nothing, there is still a monetary value and a commercial value within your pen needles themselves. So in summary, this was just, highlights with the projects and things that we're doing. So we are trying to educate our insulin patients on best practice in the insulin injection technique. We have access to a lot of tools that we can share, from information, marketing things, those sort of things, rotation charts, slider cards, all of that. And we're encouraging the pharmacists and everyone out there to help educate these patients in the best practice, get them to use the shorter needles, change their needles, and hopefully then improve their overall control around that. And then, as I said, we have the videos available that you can share with patients to get them to be able to take some information home. Right, I just want to share one other thing. So we then, there you go. We sent out a pharmacy letter. So hopefully everybody received this, or I'm not sure if you have shared it yet, Jackie, but this is then kind of summarizes the whole gist of it. So it touches on why do we want to do this? We want to beat lipos, we want to have better control, the impact of diabetes, things to remember. It was a nice leaflet that goes together, showing we're compatible with all of the insulin pens out there, which is great because you're paying.
Claire, we seem to have lost your audio again. Claire, can you hear me?
Can you hear me?
You've just come back now.
Sorry. So this just highlights everything I've mentioned in a single news flash. So if you've received that, this is what it touches on. And then, as I mentioned, just shows that we are compatible with all of the insulin pens out there, which is great for your patients. You don't have to have different needles for all the patients. And then the patient support that goes with it. We have dispensing bags, QR codes, how to scan, those sort of things. And that is it from our side.
Thank you, Claire. I think that was very informative. So that leaflet, we have sent it out in the original info flash with the invitation, but we will share it again together with Claire, if you can share your updated presentation with me. And then obviously we've recorded this evening's session. So that was incredibly useful, Claire. I think we all realize that that diabetic patients are very important patients to any healthcare provider. They are going to be returning to you for the rest of their lives. And it's wonderful to see that there's something clinically that we can assist them with, and at the same time, increase revenue in the pharmacy. It's not often we have a win-win situation like that. So at this stage, Claire, a couple of people put notes in the chat to say they were going to have load shedding, and so they might drop off. But I'm going to open up the for questions. Either type it in the chat box or just unmute and go ahead. I think maybe the first question, Claire, that I would like to ask you is those little packets. The dispensing packets, where can we get those, and where can we get the little nail clipper device which can hold 1,500 needles? Are they available through wholesalers?
Yes. So wholesalers have them. Transfarm should stock them. It's available from DSV, and then of course in turn any wholesaler that purchases from DSV is able to then have access to them. I speak under correction. The only or the challenge was that they come in a box of 24. So I'm just putting it out there up front, unless a wholesaler is willing to split the box. Maybe pharmacies, if they want to, they could split within the pharmacies or the groups themselves. So that was only one challenge why, some pharmacies didn't necessarily want it, was because of the pack of 24. But I think you're looking, the last time I looked, about 180 to 200 Rand each for the little unit, but it lasts a patient a year to 2 years. So yes, it might be a little cost, but it's a really wonderful thing. And you can literally, a lady in a handbag, a gentleman in a pocket. It's a very nice little goodie. So to answer that, yes, wholesalers from DSV or wholesalers themselves have those available. And then the dispensing bags, we actually supply them. So if the pharmacies would like, we could get a list, we could actually send it directly to them. And it's literally available from us. It's free. And as I said, it's literally, if you just, so how many, I think the pack comes with 4 rolls of 200. There's about 1,000 in a little pack, and they're the size of a bank bag. And the idea behind that is for your 30s pack. So that the 30 needles go in there. We're trying to avoid the 5 needles, 10 needles. Put your 30s in there. It's got the code on it to scan the video, and you actually send them home with some info. So any pharmacist would like that. If you could maybe, put a list together and say, right, these are the pharmacies that would like bags, we could actually arrange to send it through and deliver directly.
Wonderful, Claire. I think that's a great idea, and we will do that. Ahmed, in fact, I was just about to ask you a question, Ahmed, if you knew which medical aid funders are actually paying for the 30 needles a month. But I see Ahmed actually beat me to the question. So basically he said, Claire, thank you for an excellent presentation. can you please share the funders that have agreed to reimburse for 30 needles per pen or per month? He says he is aware that Discovery and GEMS do, but he's not sure of any of the others. Do you perhaps know, Claire?
What I'd need to just check for you, Jackie, is I know that Magda, I'm so sorry she couldn't join. She's done a lot of work with the funders, and she's got a long list that she's worked with that works on which funders are reimbursing, that sort of thing. She's also done a lot of information around claiming.
That's fine.
So, basically, the various methods of claiming, what you can claim for, how you can claim. So there's a lot of information that we've done. I don't have it with me, but that is I can actually ask Magda to share that as a follow-on point as far as the funders go. So that's.
Thanks, Claire. I think that will be very useful. So we'll get hold of Magda. And I think Ahmed as well, if we do some work, I see somebody said here that Best Med also paid for 30, because I think you're 100% correct. If we can even just get diabetics to change their needle every day, we will be keeping people out of hospitals. There are a few more questions. Oh, okay, Claire, I see you've said there. So Simone asked, what is the product description for the nail clippers? And you've said it's the BD Safe Clip. So you've answered that already. Thanks very much. And I don't see any others. Our chairman has said excellent presentation, but I will let him thank you at the end there, Claire. All right, are there any other questions? As I say, we will have the presentation for you. There are those QR codes which can take you to videos. We will share the pamphlet again, and of course the recording of this evening's presentation. Any further questions? No, everybody's saying thank you for a wonderful presentation. And Claire, at this stage, I'm going to invite Khabu Kumapi, our chairman, to unmute and just to basically thank you and to close off the session.
Thank you so much.
Thank you very much, Jackie. Thank you very much, colleagues. And most importantly, thank you very much, Claire and Magda, for the work that you have been doing behind the scenes there. I know some people are just seeing all these presentations now, but they do not know that there is a lot of work that have went in. Simone, the office, Jackie, Ahmed, Magda, and Claire, the BD team, we really appreciate the work and the relentless efforts into ensuring that these diabetes patients are being taken care of in a proper manner. And I must emphasize that it is our responsibility and duty as pharmacists to ensure that there is proper usage of needles and techniques and all those things. It is indeed in our spectrum of work to ensure that a single-use needle, for example, must be emphasized. And I believe that the work that has been done by BD and Magda in ensuring that the funders and the schemes are on board to ensure that they pay for 30 must be followed up vigorously, Jackie, through the office there to ensure that all schemes are ultimately paying for the 30 needles, and we can then take it up to our patients to say, we have now negotiated that you get 30 needles, please use them properly and ensure that you do not injure yourself and accumulate all these unnecessary side effects due to the blunt needles that you are using repeatedly. This is a good work. We are starting off, and I believe that in the next meeting, when we're engaging with BD, we should see an improvement from those stats. Those 40,000 versus 20,000, 27,000 needles must at least be at 37 to 40, if it not equal. And that is the work that we're now going to be taking up as pharmacists. But this evening, colleagues, let me just say thank you for availing yourselves and the time you took to be with us tonight. We appreciate your time and your presence here. And we must indeed send all the gratitude to also BD for ensuring that they educate us on these matters that are so important in clinical pharmacy, which is what we are gearing towards in the upcoming years. So colleagues, thank you very much. Let me not take up much of your time, noting that there is load shedding and all sorts of inconveniences. But indeed, it is a thank you from ICPA. It is a thank you from BD. Until we meet again, let it be a good night and a good week. Thank you so much.
Thank you very much, Kabo. Claire, just before you go, I see there is a hand up from Quibus LaRue. Quibus?
Sorry, Jackie, I was battling with the computer. I just want to ask Claire, she's actually a patient and a client of mine, so it's nice having her on the other side of the thing. But I just want to ask, a lot of us has got TV screens in the pharmacy. Maybe if we can produce a short little video that can play for our patients, you know, and just notify them of what is available and what they need to do, because a lot of diabetes patients wait for their medicines and then they can watch the video.
Thanks, Chris. You know, that is actually excellent. We are currently in development to do short video clips on how to inject. So there's similar video on the injection technique and also in different languages. So we're currently busy with one in Afrikaans, I think one in Xhosa. We've already done in I think Swahili for up in Africa. So we're actually looking to get some of these video clips translated to be much more local content. So we are busy with that. I love that suggestion and I'll definitely put it forward. So the minute we have some clips that you can run on screens, we will definitely share it. You'll be one of the first we can share with. So we are in that process of doing that.
Thank you very much, Claire. Thanks for a brilliant presentation.
Thanks.
Thank you very much, Kobos.
Thanks,
you very
everybody.
much.
Thank you, Kabo. Thank you so much, Jackie.
Back to you.
Have a good evening.
Yes, good evening, Claire. Thank you very much. And everybody that's still on here, please read your info flashes. We need to know which pharmacies want to participate in our diabetes campaign, as we are sourcing free testing strips. So look out for an info flash this week and send your names into ICPA. Thanks, everybody. Have a lovely evening.
Excellent.
Bye-bye.
Thank you very much. Bye-bye.
Thank you. Bye-bye. Bye-bye.